Thank you very much. So, before I start talking about gastric balloons, I should do the disclosures. And the first thing to say, actually, is I'm in charge of balloons. I've got a bearers in, I've got a lawyer in. So, I don't want to be too dogmatic, but I spoke to Sanjay before, and he said, look, be a politician, just sell what you don't believe in and go for it. So, I'm going to do a full debate to try and push this idea that the balloon is effectively dead. So, when I started looking at this topic, I thought, well, how do we do it? Well, let's look at balloons and let's ask a simple question. What do the balloon manufacturers and inserters, what do they say? So I went to one of the websites and I found this statement. I said, although weight loss with a balloon is slower in that seen after bariatric surgery, their point was the balloon is safer and it was cheaper, and that was the reason they were advocating it. So using these sort of criteria, I said, all right, let's have a look and let's compare balloons to medication. So this is just a summary, and what I've done is summarise in the table the sort of weight loss results that we've seen with GLP-1s, and I've used a survey study, which is a New England Surgical publication, and I've compared it with fluid-filled balloons and soil balloons, based on the biggest meta-analyses I could find in literature. The first thing to say is that the GLP-1 is showing a 16% weight loss at 6 months, which is more than both the fluid-filled balloons and the soil balloons. But the key point is that when we move on, at 12 months, the GLP-1 is showing 20% weight loss, whereas the fluid-filled balloons and the soil balloons are actually showing some degree of weight regain. And the interesting thing is that 18 months, this again is in the Sermon study, we're seeing 22% weight loss in the patient group. Versus, well, there's no results I can find in 18 months because the reality is we know that the balloons come out, the weight goes up. If you believe in the hormonal theory, that has to be true. So, what we're seeing is at the early stage, better weight loss, the middle stage, better weight loss, and the long stage, much, much better weight loss, either double with either swallow or fluid balloons. So, clearly, from a weight perspective, there's really no doubt GLP-1s are better. But, is it safe? And I've got a little headline from the Daily Mail. That's
my slide, I've used that one.
Yeah. It's clearly a non-histrionic headline, clearly, because it's a Daily Mail. But what's it said? Britain's first weight jab death. This is one of the cases which needed the news. It was actually something actually my hometown there. Proud of something. So we seem to have had the first fat jab death. So, headlines aside, what's the reality? What's the truth? Well, let's look at the safety of GLP-1. Now, I was planning to do a big slide and compare GLP-1, medication, different types of balloon, but actually I've made it a lot simpler than that. I went to the Sermon study, New England Journal published study, and I basically looked at that, saying, what was the result from the study? But I think the most impressive thing is this. If you look at the serious adverse events, the tirzepatide at the highest dose is 5.1%. The placebo is 6.8%. You don't really need to go much further. Yes, there's complication with nausea. Yes, there's complication with balloon intolerance. But frankly, if you look at the data in terms of serious events, tirzepatide is safer than taking nothing. Tirzepatide is safer than the placebo. And again, if you look at the death rate, that's also true. And one thing which is often mentioned about balloons is, oh, well, a lot of people are intolerant. Well, actually, if you look at the adverse effects leading to cessation medication, it's about 6% for tirzepatide. And again, if you look at the meta-analyses for balloons, it's about 5 to 6% for balloon removal. And the difference is, if you stop taking tirzepatide, you just don't inject yourself. If you've got a problem with the balloon, you actually need to have an endoscopy and an endoscopic procedure, surgical procedure, to remove it. So on the one hand, you've got 6% incidence of cessation, you don't jab yourself, versus a 6% incidence of having to have an emergency endoscopy. So clearly quite different. So that's great, and often you present this data and say, yes, but it's not real world, it's biased, it's a randomized control trial, it can't really be extended. So I said, fine, let's look at what the regulators have to say. Because again, the regulators, the ones who are independent, the governmental organisations, they don't have a dog in the fight. What's their view on GLP-1s? So the MHRA have come out very clearly, and they've said that when you look at GLP-1s, the adverse reaction report doesn't mean the medication has caused a suspected the actual hospitalisation. So, for example, the Daily Mail article that I just quoted, the patient actually died of pancreatitis and had a history of gallstones, but because she had 2 jabs, it was completely put down to the jab. The reality is, it's almost certainly not. It's pre-existing pathology. And what the MHRA said very clearly is that on the basis of the current evidence, the benefits of GLP-1s outweigh its potential risks for use of licensed medication. So, we talked about what the regulator said about GLP-1. It's only fair we're in a debate to see what's the regulator said about balloons. Well, did have a look. There was an FDA alert in 2017 and in 2020 about the safety of balloons, and the FDA said that the risk of liquid film gastric balloons overinflating, the risk of development of pancreatitis were of concern. And following this FDA alert, one of the reshaped balloons was actually withdrawn from the market. So clearly there is a problem. And very recently, in August of this year, the French Medical Safety Association has withdrawn immediately swallowable gastric balloons from the French market to protect health and safety. So on one hand, you've got the NRG actually saying medication is safe, and here you have 2 separate independent authorities talking about the safety, and in one case, withdrawing it urgently from the market. That clearly is not a good thing. So, we've talked about efficacy, we've talked about safety. I think we can show that balloons are less efficacious in terms of weight loss and have more complications. But the last thing in that initial slide is cost. Let's talk about cost. Gastric balloon package price, and this is from sort of UK data, it's about £4,000 to £6,000 that's what the patient pays. The clinician fee for the balloon session is up to about £1,000 including consultation. Let's compare that to a GLP-1 agonist. At present, a year's cost for a GLP-1 agonist is £1,800. So it's about half to a third of the cost. And the clinician fee is about £150. So that's a tenth. Now the other thing is, if you look at the trend, gastric balloon prices and surgeons have all increased over time. And that's probably due to inflation and standard price pressures. But GLP agonist costs are forecast to be reduced quite significantly due to a combination of things: competition, there are lots of drugs out there now, and also patent expiry. And NICE are now estimating that in about 7 years' time, the estimated cost of a GLP-1 agonist is about £20 a month. And that is based on their experience with the statin and that exactly the same pattern. So we have an issue now where we've got intervention which is cheaper, better, and safer, and somewhat provocatively put this up. Do we have, as surgeons or clinicians, a conflict of interest? Is it ethical for a clinician to advocate to a patient treatment we know to be more dangerous, more expensive, or less effective than one which earns them a lower professional fee? That's the question. And as my last slide, whenever you want to ask a question about which is better, I always ask a simple question: what is the wisdom of the markets? I follow the money. This is the share price of the big GLP-1 manufacturer, and flashing now, what you can see is it's gone up from 264 to 800, so we've had a 400% increase in the share price of this GLP manufacturer. This is the slide of the balloon manufacturer, and what you can see there is it's gone down in the last 2.5 years by 85%. So the markets clearly have made a decision to get balloons ahead. So the question is, are we going to make the same decision clinically? Thank you.
Thank you very much. I think if there's one man in this room who's going to argue this, it's Mr. Loy.
Thank you, Mr.
You are the man.
Thank you. The talk is a little bit up, is it? Let's see if I can press the button to start it. Probably rushing to see yourself on Saturday or something. Let's see. There we go. Okay, so I'm here to argue. As every year, Sanjay gives me something very controversial, as Novo Nordisk are one of the sponsors this year, so I'm on dangerous territory. But Omar, a very respected surgeon in the UK, we must listen to what he says. But Omar, you have sat down there thinking you've done a fabulous job. I'm going to tell you, look, if you come for the king, you better not miss. scratch it on my ear right now. So, look, I'm not here to say that GLP-1 agonists are bad. I actually think they're good. I think in the ecosystem of bariatric surgery and weight loss, it's becoming a massive problem worldwide. And I think the balloon does have a place. The gastric balloon lives within this ecosystem. It is doing a good job, and the GLP-1s will act probably in the future in combination. So I'm going to argue the points on safety, on efficacy, and of course on cost. And we'll have a little look at the stock market at the end. Okay. So, what are the advantages of intragastric balloons over other procedures? Well, it's minimally invasive. I put in the Allurian balloon. I've stopped doing the other balloons because time and intervention and sedation and needles and endoscopy. And the Allurian balloon's in about 15 minutes. It's a day-case procedure. We can take it out very quickly. We can repeat it if necessary, and it preserves the GI anatomy. How do they work? Well, there are a lot of similarities between the GLP-1 and the obesity medications in the balloon. 3 potential pathways have been postulated, and of course the balloon only works if you want to change your lifestyle, if you want to change your diet and exercise. So, just like your GLP-1s that you're very fond of, it delays gastric emptying, making the patient feel fuller for longer. It takes up space in the stomach, physically reducing the amount of food that you can eat, and there's also some vagal nerve stimulation. The balloon has been around for a while, and we can look here comparing the various balloons. We've got the heliosphere, we've got the Obera balloon, and then the one that I use is the Allurian, the swallowable intragastric balloon pill, which again doesn't require endoscopy. And when compared with the weight loss, so the efficacy, we look at the Zepbound, we look at the Wegovy, and there are similar results over the first 12 to 18 months. And if we look at again the 62% of patients who were on semaglutide and 38% of patients who were on tirzepatide, they did not achieve greater than 10% total body weight loss at 1 year. So you've talked about safety, and safety is paramount to what we do as surgeons and as physicians. And since I've moved to the Allurian pill balloon, my early explant rate has reduced from about 1 in 50 to 1 in 200. So I put in over 500 of these now. I've had to take out 2 of them early due to intolerance. I think that's for a number of reasons. Most importantly, I think it's to do with the material that the balloon is made from. It's made from polyurethane, whereas the other balloons are made from silicon, and I think they're more heritable on the stomach. And interestingly, this is published only a week ago, showing that a third of patients, this is in the SELECT trial, discontinue their GLP-1 medications at 1 year. So it's causing sickness, it's causing vomiting, it's causing GI upset, and patients just don't like it. I think that'll change as various newer medications come on the market, but for now, I think there's a 33% rate of discontinuation of the GLP-1s at 1 year. And of course, our Daily Mail, our beloved Daily Mail, we've had the first death in the UK. So, look, this is early days for the GLP-1s. We mustn't ignore that. We must say that actually this is something that we need to keep an eye on. So it's not writing it off. I'm not against the drugs at all, but I do think we need to be careful in our work. And of course, we look at the stock market, the costs, etc. So about a week ago, Amgen, who are making Mariatide, lost 12 billion of their stock value. So in a market that's worth 150 billion, that's quite significant. And why was that? Well, somebody found a hidden Excel tab at the back looking at bone density. And looking at bone density, they said there was potentially an impact on bone density in these patients that wasn't reported earlier. So how that tab was not revealed, I don't know. But over one day, on the 12th of November this year, 12 billion was wiped off the stock of Mariatide. And that's Amgen in America. It's since recovered somewhat in that they said they accidentally forgot to put it in. Okay? I actually think that the GLP-1 agonist and I think the balloon will work in combination together. There is what's called a churn. When the balloon comes out, yes indeed, the worry is that the weight will go on. And it may well be that in this scenario, for example, scenario 1, the patient joins the program, they have the balloon at the start, they start to lose the weight, and then after a couple of months you can introduce your GLP-1s. And that will allow the patient to overlap with the balloon and the GLP-1. It can come afterwards or it can come before. But there is definitely a lot of research needed to see which combination will work best. So in conclusion, I think the balloon is safe. The significant adverse events of the Allurium are minimal. The results are good over 18 months. Patient choice is important. Patients sometimes say, doctor, I don't want to risk something that will potentially make me sick. That's expensive right now, that I cannot get hold of if I'm in the UK. And perhaps I can take something that will help me in the sort of the short term. So on that basis, I believe the balloon is alive and as well, and I hope I proved that to you bigly. Thank you very much.
Come back to the front. Do we have any questions from the audience before we take the photos?
Thank you so much for the talk from both sides. I mean, from my end, when I think about these medications or the balloons, if we think about obesity as we think, it's a chronic disease, and you have mix of hormones, genetics, environment, psychology. None of these two interventions will work on the long run, because both of them potentially, once you stop them, unless you change that combination or triad of genetics, hormones, environment, they're going to come back and gain weight, which is, I think, good for the industry, because you always like to have a returning customer. You don't want to sell and solve the problem. So if you look from that perspective, it might be that GLP-1 on the long run will be more sustainable if the price drops, and we can start seeing long-term side effects, and they are within acceptable. Well, I think the balloons, even though if you can take it twice and 3 times on the long run, it's not sustainable. So that's why I would lean more towards GLP-1 if the evidence on the long run show it to be potentially sustainable, because that's how you're going to control obesity on the long run, because you can't control it with a short-term intervention. Thank you.
Well, I think we're operating as surgeons on 1/4% of eligible patients. So even if we were to all in this room operate morning and night, we'd never get through the amount of patients we need. So there needs to be an alternative for those patients. There needs to be an effective treatment for those who are not quite surgery eligible, but heading towards the diabetes, heading towards the sleep apnea, the blood pressure, and both the balloon and the GLP-1s are perfect in that.
Yeah, I mean, that's why I think that GLP-1 could potentially be a long-term solution if we can accept a lower long-term side effect.
I'd probably just add one thing about the GLP-1s. If you take weight aside, there's growing evidence for multiple improvements in comorbidities, heart failure, there's evidence of Alzheimer's. So actually, it is a bit like a statin in some ways. That yes, you need to take it for life, but frankly, so what? Someone who's hypertensive is on amlodipine for life. We don't concern, we're not too concerned about that. So I'd quite say to go for GLP-1.
I think these were 2 fantastic talks. I just wanted to ask you, in most European countries, the costs for GLP-1 are higher than 1,800 pounds per year, and you were a little bit cheeky because you were presenting the weight loss data for the single dual agonists, but when it came to the costs, you suddenly flipped, I think not to tirzepatide, but you showed the costs for liraglutide maybe. You want to comment on that?
I'm going to have to defend myself now. What I actually did was I went online last night to Boots Online or Chemist Online and asked how much the jar was, multiplied by 12. So that's what I've done. I think they're probably discounting, it's probably less, but the one thing I would say is we know the costs are going to come down, because we see that with statins, they will come down.
Yeah. I mean, the patents for liraglutide already expired, and Novo was thinking to stop the production entirely because they were expecting some Chinese or whatever company producing it for nothing, but actually that did not happen until now.
Simon?
Thank you both for fantastic talks. The balloon complication rate is clearly hugely underreported, because most people present to the NHS and balloons are removed left, right, and centre without being reported anywhere. Even Allurium themselves aren't fully honest about complications in their literature. So I am a convert away from balloons.
It's interesting the point about the French market. wasn't the device, the French authorities have said that the device can stay, they want explanted devices. It was the type of clinic that was putting them in, it was more like a cosmetic clinic, unsupervised. So it wasn't the device, it was the environment in which it was put in that caused the problem.
Yes, right.
Yeah, right. So I have been using balloon as well as GLP-1. So I see a result of weight loss coming down beyond 6 to 9 months even with the GLP-1. We have tried under 28 milligrams as well in our series 4. In the long run, maybe the metabolic effect may be there, the weight loss effect might be a problem with GLP-1. Second thing is, if the patient wants a good weight loss pretty much in a very shorter time, then when we add balloon and GLP-1 together, then we are having a very good result. Low dose 3 milligrams, 7 milligrams semaglutide with the balloon helps in a very big way. We use Alluvion, we use even SPATS 3 balloon where we titrate the balloon volume. We have a very good result of 25% weight loss in 6 to 9 months itself. So that way, I think, of course, both have to coexist, but GLP-1 on long term for weight loss may be a question mark, for metabolic resolution may be good.
And that's why Allurion this week, the stocks have launched again. They announced Allurion meds, so they're also going to combine the meds and the virtual personal platform and the balloon, because that's the future.
And we talk about that sequential, when the weight loss stops, when we add a balloon again, they start losing again. I don't know what is the reason behind it. Maybe that could be the effect of satiety going down with GLP-1 on a long term, where a short term balloon inside might hit it again. I don't know. Maybe the reason.
I'd add one thing, that if you want short-term weight loss, excessive short-term weight loss, you've got to ask the question why. If it is a bridging procedure, I can sort of understand, but if it's, I don't know, to get into your wedding dress, that's not a good reason to combine two modalities. And I think the other thing I'd say is that we're talking about the first generation of GLP-1s. The Tutrikite is going to be released soon, which is 25% weight loss. We're talking about medications which are rivaling, forget balloons, surgery. So we do have to have what we'll talk about tomorrow. We do have to think in the longer term.
Even that 25% weight loss, it's a short-term weight loss. In a long term, there is no study proved GLP-1 is going to have a sustainable weight loss. We have 2 years of study, weight regain happens, or weight loss stops beyond a point with GLP-1. So everything is 6 or 9 month study, and then if you stop a GLP-1, more than 70% of them gain weight again. So yes, it has its role, but it is not the go-to pill. As he said, it's a multimodal treatment option. It has to be multimodal, maybe with surgery and pharmacotherapy, or pharmacotherapy and balloon combination. If you want weight loss and metabolic resolution, if you want only metabolic resolution, maybe I will go only with GLP-1.
Thank you. What we haven't talked about here is wraparound care, which I think is important, but we're not going to talk about it. We're going to have a vote. So, could all those in favour of the motion put forward by Professor Khan that obesity meds have put the gastric balloon out to pasture raise their hands? Okay,
I'd say that's about 35%.
30. Okay, excellent. I do like your stats, John. There may be some
Your Fox News, I'm seeing.
there may be some undecideds, of course, and he's and those who believe in Mr. Loy, could they raise their hands?
We make bariatrics great again.
So I think that's fairly.
The chairs never didn't raise their
The
hands.
chairs, well, which of us is Donald Trump? Who knows? Thank you very much, gentlemen, for excellent debate.
Okay, so the next part of the session is about strategies for recovery.